everyone, this is a video about septic abortion for our CREOG Video Project. Septic abortion is defined as a clinical diagnosis of infection following any abortion, spontaneous or induced, less than 20-week gestational age that is complicated by infection. Presenting signs and symptoms are often pelvic or abdominal pain, uterine tenderness to palpation, purulent vaginal discharge, vaginal bleeding, and fever. Severe infection may present with a fever of greater than 38 Celsius, hypothermia, tachypnea, tachycardia, and or leukocytosis. So remember, the septic abortion and septic is because this could rapidly progress into sepsis or septic shock. So UpToDate has a wonderful algorithm for the initial evaluation and management of patients with suspected septic abortion. Again, these will be patients with pregnancy less than 20 weeks of gestation or history of pregnancy who present with pelvic pain, uterine tenderness, vaginal bleeding, and or discharge, and or fever. So in order to evaluate persons for this septic abortion, you want to get a targeted history including LMP and likelihood of pregnancy, and then obtain laboratory tests. You do want to get blood cultures for concern for sepsis. You may perform an STI screen for possible causes of infection, although the most common causes are usually vaginal flora and anaerobic bacteria that gain access into the uterus and cause infection. Serum tests that are recommended to get is a CBC with differential, CMP, lactate level, PT, PTT fibrinogen, and a type-in screen. So the CBC is to evaluate for hemoglobin and for a white count. The PT, PTT, and fibrinogen are to evaluate for concern for DIC, which could be a complication of septic abortion. And of course, lactate level as well could evaluate for sepsis. You may also get a urinalysis and urine culture. And then the algorithm will divide people into the following. So either hemodynamically stable or hemodynamically unstable, and or meeting 2 or more criteria of CREOG, which is the table here. So if they do meet that criteria, or if they're hemodynamically unstable, you presume septic abortion and begin emergency resuscitation and care, which includes stabilize with hemodynamic support, including aggressive resuscitation with IV fluids and supportive blood pressure, initiate broad-spectrum IV antibiotics and other empiric therapies, perform uterine aspiration, ideally with ultrasound guidance, and do not use sharp curettage. And we'll talk a little bit later about why. And then perform aerobic and anaerobic cultures of tissue, obtain a time of uterine evacuation. The common antibiotic regimens that we do use for septic abortion are gentamicin, 5 mg per kg per day, IV, plus ampicillin, 2 grams IV every 4 hours, plus metronidazole, 500 milligrams IV every 8 hours, or instead of metronidazole, you may use clindamycin, 900 milligrams IV every 8 hours. Ideally, these antibiotics are to be used until a culture returns so you can better treat according to the organism. Once a patient is stable, you will discharge them with 10 to 14 days of oral antibiotics, which are usually doxycycline 100 milligram BID or metronidazole 500 BID. If a patient is stable, then you may take the time to perform a pelvic ultrasound to identify if there's an IUP, if there's frank products of conception, or any evidence of extension of infection such as a TOA. Again, ultrasound measurement of endometrial thickness by itself does not predict need for surgical intervention. However, an endometrial thickness greater than 1.5 centimeter does kind of increase our suspicion for retained products of conception. The next question in the algorithm in a stable patient is there evidence of another source for the patient's symptoms? So if a pregnancy is greater than 20 weeks, we do consider that more an endometritis picture rather than a septic abortion. And then, of course, we follow along the lab test that we did to watch for possible urinary tract infection, plus or minus pyelo, or an appendicitis picture, which the patient should ideally be evaluated for when they present to the emergency room. And then if there is, then you obviously treat the identified cause, but if there's not, then septic abortion is confirmed by ruling out other diagnoses. So you proceed as above with empiric treatment, including IV fluids, broad-spectrum antibiotics, and then surgical uterine evacuation. So I do have a couple of CREOG TrueLearn questions that we can go over that I found when searching the topic of septic abortion. Unfortunately, there aren't that many, but it is still a high-yield topic for CREOG. Question 1. A 25-year-old G2P1 patient is seen in the emergency department at 5 weeks gestation with complaints of fever and midline abdominal pain. She has tachycardia, and a TVUS demonstrates absent cardiac activity. A suction dilation and curettage is performed, and on removal of the suction curette, a fatty yellow tissue is noted. So which of the following is the most appropriate management of this patient? A. Assessment with uterine sound. B. Completion of the procedure using sharp curettage. C. Completion of the procedure using ultrasound guidance. D. Diagnostic hysteroscopy. Or E. Diagnostic laparoscopy. And the answer is E. Diagnostic laparoscopy. So as we know, when we consent people for a dilation and curettage, the complications or possible complications are bleeding, damage to nearby organs, and uterine perforation. The risk of perforation is increased in septic abortion because the infected uterus is less able to contract appropriately and will often be more boggy, and it is easier to perf through. Ways to identify the perforation. So if sharp curettage, then you'll probably notice that you no longer have resistance when you reach the fundus, and the instrument will advance much further than it did prior. If you're using suction curettage, omentum entering curette is a sign of perforation, although similarly you may advance it further or not feel any resistance anymore. This is one of the reasons why sharp curettage is not recommended, because it is easier to perf through, although as we can see, it can also happen with suction curettage. So the TLDR for this question: if entry during D&C is performed by sharp or suction curettage and perforation occurs, laparoscopy is required to explore for significant damage like hitting bowel, bladder, or vasculature. If entry during D&C is performed by other instruments, such as a sound, perforation is less likely to cause significant damage, and hysteroscopy may be used to further explore the injury. On to our last question. Which of the following is the most appropriate management for a suspected septic abortion with CT findings concerning for a Clostridium infection? A. Blood cultures. B. Diagnostic laparoscopy. C. Endometrial biopsy. D. Hysterectomy. Or E. A surgical D&C. The answer is hysterectomy. So in general, as we went over, the management of septic abortion is evaluation and stabilization of vital signs, initiation of broad-spectrum antibiotics, and evacuation of uterine contents. However, findings of Clostridium infection, aka concern for neck fash, include crepitation of pelvic or abdominal structures on exam, woody appearing uterus on laparoscopy, or air within the myometrium on radiologic imaging. If Clostridium is suspected, treatment must include hysterectomy with bilateral removal of the adnexa. And that is all. Here are my references. Unfortunately, ACOG and other resources don't refer directly to septic abortion, but UpToDate is a great resource that I do highly recommend reviewing.